Hi folks, and welcome, and thank you for joining us, our Medical Assistance in Dying webinar. So my name is Darlene O'Reilly, and I am a registered nurse and a practice and standards consultant. I'm joined by Tracy Olson, a practice consultant from the College of Licensed Practical Nurses of Manitoba, and Ryan Shymko, a practice consultant and deputy registrar from the College of Registered Psychiatric Nurses of Manitoba. There are a few guidelines I want to cover before we get started. This webinar is being presented on Wednesday, December the 21st, and is being recorded to be available on each of our websites. If you'd like to watch it again, or for those of you who were not able to join us today. I'll just take a few minutes to review our objectives. So we're going to talk about Bill C-14. We're going to review Conscientious Objection. We'll go over what is counseling, and then we'll talk about what this means for nursing practice in Manitoba. First, we have a question. I'm just going to set up a poll here. So we just wanted an idea of the climate out there and who has been involved in medical assistance in dying, either providing information for clients or just having clients asking questions. So I'm just asking you to answer this on the poll, and we'll leave this open, and we'll take a few minutes to have people respond. So I'm just going to close that poll now, and it looks like we have 70% or 71% that have not participated. And so what we have is 29% who have participated and 71% who have not. And we've had 96% of the people who have voted, so that's great. Thank you so much for participating in that. So the next few slides, I'll just go over some of the information out of Bill C-14. So first of all, what forms of medical assistance in dying are permitted? So Bill C-14 allows two types of medical assistance in dying, where a physician or a nurse practitioner directly administer a substance that causes the death of a person who has requested it. It's commonly known as voluntary euthanasia. And the second type is where a physician or nurse practitioner gives or prescribes to a person a substance that they can self-administer to cause their own death, commonly known as physician or medically assisted suicide. So I will mention that currently in Manitoba, nurse practitioners are not able to sign a death certificate, so it makes it difficult to be able to actively participate in providing the substance that causes death. However, nurse practitioners can be involved in the assessment portion to determine eligibility. So in Bill C-14, there are some exemptions. So a medical practitioner or a nurse practitioner are exempted. A person assisting a medical practitioner or a nurse practitioner, such as a registered nurse or a licensed practical nurse or a registered psychiatric nurse. And pharmacists are exempt. So the eligibility, so persons who are eligible for health services funded by the Government of Canada, they have to be at least 18 years of age, have a grievous and irremediable medical condition, a voluntary request, and have an informed consent. And people must meet all of these eligibility criteria in order to be eligible for medical assistance in dying. So just to review grievous and irremediable, it is a serious or incurable illness, disease, or disability. There's an advanced state of irreversible decline in capability, suffering that is intolerable and cannot be relieved under the conditions acceptable to that person. and that natural death has become reasonably foreseeable. So some of the safeguards that are in place is that clients requesting a medical assistance in dying must meet all of the eligibility criteria that I spoke about earlier. There has to be a written request dated and signed. Clients are to be informed that they can withdraw at any time. A second opinion by another independent practitioner is required, and that 10 days between the request and the provision of the service of medical assistance in dying needs to occur. And immediately before the service is provided, the opportunity for the client to withdraw is asked. And just to note that that 10 days can be shortened if the client is deteriorating quickly and there may be a chance that capacity could be questioned. And so the medical assistance in dying team in Manitoba has the opportunity to make that time shorter if they feel that's warranted. And I'll pass this over to Tracy.
Thanks, Darlene. Hi, everyone. This is Tracy. I'm from the College of LPNs, so I'll just continue now. The bill also has some amended definitions of various terms in the Pension Act and the Canadian Forces Members and Veterans Reestablishment and Compensation Act to ensure that a Canadian Forces member or veteran would not have their survivor's entitlement to pensions or other benefits affected should they receive medical assistance in dying. So these amendments to these two acts would also deem that a member or a veteran's death in these circumstances would be considered as resulting from their underlying medical condition and not from medical assistance in dying itself. The bill also amends Section 19 of the Corrections and Conditional Release Act to clarify that if a federal inmate were to receive medical assistance in dying, there would not be a requirement for the Correctional Service of Canada to conduct a separate investigation into such a death. So in healthcare, conscientious objection is generally understood as a healthcare professional's refusal to provide a service that is within their competence. Conscientious objection raises many complex issues, such as conflict of interest and how to balance these between ethical practice and access to service without delay or judgment. It's driven by moral concerns or beliefs and is informed by reflective choice. It is not based on fear, prejudice, or convenience. Nurses must reflect on medical assistance in dying and determine whether it's compatible with their personal, ethical, and/or religious beliefs. If it isn't, they may choose not to participate on the basis of a conscientious objection. The topic of medical assistance in dying raises many polarizing thoughts and emotions among team members. It's a very individual choice, and we need to consider whether we can choose to be a part of this provision of care or not. This decision cannot be taken lightly, meaning there must be a great deal of thought and personal reflection put into this decision. So then how do we then address and prioritize our values, both our professional and personal values? So a common understanding of conscience is that it encompasses one's moral beliefs about right and wrong, otherwise our personal values. These beliefs can be worldly or religious and are usually well established by early adulthood. But our values may also change over time as we gain new experiences that question our value system. Most people hold a wide variety of moral beliefs and values. Our beliefs vary within how convinced we are of their truth and their importance to us. So for example, an individual may value the opportunity to choose their own destiny that medical assistance in dying presents, but that may cause conflict with family members who are not ready for the individual's death, or they're not supportive of medical assistance in dying. Each individual in this example presents a conscious choice reflecting their own personal values. So although each individual nurse has their own values and moral beliefs on what is right and what is wrong. As members of a profession, you also adopt the values of your respective nursing profession, as outlined in each profession's code of ethics. Although each of our nursing professions have our own code of ethics, for the most part, they contain the same fundamentals. As an example, each profession's code of ethics outlines that the professions value client-centered care, which is supported through value statements such as promoting and respecting informed decision-making for CRNM members, and for CLPNM members, client-centered care is supported by the statement informed decision-making. Then the statement respects people's autonomy and their right to choice by recognizing them as full partners in decision-making for CRPNM members. So the value of delivering client-centered care holds true for all nursing professionals. So while it's important for nurses to reflect on their personal and professional values, it's imperative for nurses to understand their responsibilities as they relate to medical assistance in dying. It's important for nurses to familiarize themselves with the amendments to the Criminal Code and with guiding documents from your nursing regulatory colleges surrounding medical assistance in dying, and such information may be found on all 3 college websites. It's also important for nurses to understand and adhere to applicable policies and procedures that are in place in your practice area that speak to medical assistance in dying, and always ensure you're practicing in accordance with all other applicable laws, rules, and standards. Nurses working with clients who are making decisions about end-of-life care can continue to care for these clients as they have done up to this point. However, it is prudent to recognize what may be construed as participating in a medically assisted death. For example, there is a difference between initiating an IV line for the sole purpose of administering a substance that would terminate a client's life versus doing so to administer a substance that is part of the client's normal course of treatment. If a nurse is asked to initiate an IV line for the purpose of facilitating an authorized provider's administration of a substance that causes a client's death, this may be considered to be participating in medical assistance in dying, and the nurse must make the necessary inquiries to satisfy him or herself that the client has met the legal requirements and criteria for a medically assisted death. Nurses may be asked to be a part of a designated group of health professionals who provide medical assistance in death services. As a member of such a team, the nurse will continue to be able to share information about medical assistance in dying with inquiring patients. However, the nurse should be mindful of their role within the team as well as the regulatory and legislative limitations placed on them with respect to medical assistance in dying. Further, the nurse may want to seek legal advice, such as referring to the Canadian Nurses Protective Society or even independent counsel. So now I'm going to pass this on to Ryan.
Hello everyone, I'm going to bring us home, and we're going to discuss a little bit about the counseling in the context of medical assistance in dying. So it is important for nurses to understand that there is a difference in the context in which the term counseling is being used with regards to medical assistance in dying. So for the purposes of the Criminal Code, counsel refers to the concepts of procure, solicit, and incite. This is important to note because as most healthcare professionals and as nurses, we often use the word counsel or counseling within a therapeutic relationship as a means of communication, information sharing, active listening, client education, and the provision of psychological support. So therefore, it's acceptable for the client to raise the issue with a nurse. However, the nurse cannot incite medical assistance in dying by asking the client if they would like to access medical assistance in dying. The appropriate path in this instance might be to discuss the client's pain and or suffering, or to make a referral to a physician if the client has directly asked for information. It would be acceptable as well to point the client to the medical assistance in dying website or to provide them information about it. So from our education day that we participated with the College of Registered Nurses in September, we developed a list of do's and don'ts, and these are kind of reminders that you can take with you, throughout your practice in terms of how to access and how to use medical assistance in dying. So the first do would be to acknowledge the client's request in a caring and compassionate manner. Also, you might want to explore the client's suffering. So it might be a conversation that goes outside the whole context of medical assistance in dying. And we also encourage you as practitioners to collaborate with your colleagues and your employer to meet your client needs. We also say consult your regulatory college. That's why we have myself and Darlene and Tracy at our respective colleges. So if you have questions about medical assistance in dying and how it applies to your own practice, you can always feel free to give us a call at each of our respective colleges. You can also explore your own feelings about how you will participate in medical assistance in dying. And I think this is a really important take-home point as we've been talking with some of our regulated members from the 3 colleges. People have noted that they have felt somewhat comfortable with the concept, and then when they've actually been invited to participate in medical assistance in dying, they've had some reservations and some internal anxiety about the issue itself. So I think it's really important for us as nurses to reflect, and I think it's a continual process that we need to keep doing. It's also important for us as practitioners to make referrals as appropriate. If you're not sure how to answer a specific question, it's okay to make a referral, and it's okay to consult with other practitioners. And I think the big piece as well with the do's and don'ts is this whole concept of documenting. And I think much in the way that we document our interactions with our clients and the medical and psychological care that we provide, in the context of medical assistance in dying, it's really important for us as practitioners to document our conversations that we're having with clients. So some don'ts. Don't ignore a request for information on medical assistance in dying. If the client comes to you and they want to speak about their suffering and their pain and they make a specific request for medical assistance in dying, it's important to try to address that as best as you can. Again, don't counsel on medical assistance in dying. So in this case, it would be if the client specifically asks you about medical assistance in dying, you can provide them information, but don't offer that to the client if they haven't made that request. Also, don't minimize the client's request or feelings. Try to acknowledge it in a caring and compassionate manner. Don't provide information on medical assistance in dying unless the client explicitly asks for it. And I think this is also an important take-home point because I have seen mixed messages in terms of what type of information we can offer as nurses. In a couple of presentations that I've attended from legal counsel from various areas, they have said that you do not provide medical assistance in dying unless the client specifically asks for it. And then the last one, don't guess or speculate. Make sure that the information that you're giving the client is correct. It's okay if you don't have the information that time to come back to them and say, you know what, I will look into this and I will provide you with a response at a later time. So with the concept of informed choice, as nurses, you are going to have to make an informed choice as to whether you will participate in medical assistance in dying if it presents in your facility or in your program or on your unit. You'll need to carefully balance your duty to provide care versus your right to morally object to provide a specific service. Regardless of your nursing role and where you practice, you need to be prepared if medical assistance in dying arises within your practice area. It's important to take the time to reflect on your decisions regarding medical assistance in dying. If you are uncomfortable in any way, there is a risk you may experience moral distress or anxiety regarding these decisions. You may also want to think about the many ways you might be asked to be involved. So some examples may include providing information to clients or to their family members, starting an IV that would be used for medical assistance in dying, care and comfort for a client and family members who have chosen medical assistance in dying, care of family members after the death of a loved one, supporting a colleague who participates in medical assistance in dying, and helping a team manage moral or ethical differences regarding medical assistance in dying. Within all of our code of ethics, within the 3 nursing professions, we all have a duty to provide care. And as I said, this guidance is outlined within each of our code of ethics. If you are consciously objecting to medical assistance in dying, it's okay to recognize the difference between a moral objection and a fear or lack of understanding. And this is one of the things I think we've also found with some of the consultations that we've done with our members is that some people have objected because they have a fear or a lack of understanding regarding medical assistance in dying. Fear or misinformation about medical assistance in dying does not absolve a nurse of their duties and their ability to provide care. If you choose not to participate due to a moral objection, you must ensure the client's continuity of care through referral or through transfer of care to another authorized health professional. Whether or not a nurse chooses to participate in medical assistance in dying, he or she has an obligation to openly discuss the client's concerns in addition to their unmet needs, feelings, and desires about their care, and to refer the client to another healthcare team member, so for example, a physician or the Medical Assistance in Dying website. So we're going to do another poll. This question is, have you acquired enough information about medical assistance in dying to be able to reflect on how you might respond to a request for information or a request to participate? Hi everyone, we're having a technical issue, so we're going to skip this poll question. But what we will say is think about this, and if you do have questions, of course, you can either ask the questions here on our board, or you can bring it back to us to each of our respective colleges, to each of the three of us. So the last piece that we have is around the concept of supportive work environments. And so one of the things that we found from work environments where there's been quite a bit of support surrounding medical assistance in dying, we found that colleagues discuss openly amongst each other in administration while respecting others' opinions and viewpoints. Supportive work environments, we've noticed, have also provided as many resources as they can to their staff. There's also facilitating of debriefing if and when this occurs within the workplace. And supportive work environments also have policies or guidelines for nurses. This is a major shift in the culture of healthcare, and those eligible for medical assistance in dying are choosing the time and place of their own death. This is not some time that has occurred really ever in our careers. In terms of our resources, we've had a number of opportunities to participate in some of the discussion and education related to medical assistance in dying, and perhaps having a resource binder that has a variety of sources within your unit may be beneficial and available to these who are not able to access direct education. So that takes us to the end of our presentation. We'll now go forward with questions. So if you have questions, please feel free to type them in, and we will answer them.
So I see we have one question on physicians and NPs being exempt, and what does that mean? And I apologize for that. I could be a little bit clearer. But what that means is that there's an exemption for physicians and nurse practitioners from criminal prosecution as long as they follow all the criteria required for medical assistance in dying. And so that also includes pharmacists and those assisting a nurse practitioner or a physician. So hopefully that answers your question. Thank you for that. Okay. So So I see we have another question. It says, if we can't provide information unless it's explicitly asked, how is this supporting informed choice? And that's a great question. Thank you for that. So in terms of liability and protection from criminal prosecution, our message has been consistent that you need to be asked about medical assistance in dying in order to provide the information. So just offering that information when a patient hasn't asked is not in your best interest in terms of liability protection. And I recognize that this is a bit different than, you know, when we're laying out all the options for patients, we usually present all the options. However, in this situation, from a liability perspective, we need to be consistent with, unless a patient asks, we do not provide that information. So thank you for that.
So we have another question. Is there a policy for nurses regarding participating in medical assistance in dying? So the three colleges, we've been doing some work together to develop, I'd say, more guidelines in terms of what medical assistance in dying means. We also have formed what we call a Medical Assistance in Dying Advisory Committee, and it's made up of members of the three colleges as well as myself, Darlene, and Tracy. And we are in the midst of developing some guidelines for practice. We have a first draft that's ready to go, and so it'll be presented to the committee sometime in January. So we will have something that we can put out to all three, or to members of all three colleges, hopefully within very early within the new year. Okay, so we have another question. The question is, I understand that the Manitoba team performs euthanasia only, and medically assisted suicide is not an option. I noted that in locations where the medically assisted suicide option is available, there are folks who elect not to use it and die naturally. Why did our system adopt the euthanasia option only? So that's a bit of a tougher question. My understanding right now is that BC is the only province that is actually using the euthanasia option. I could be incorrect on that. For Manitoba purposes, my understanding is that because the medications are not available, we haven't used that option. So as of right now, we are only using the medical assistance in dying option in this province. And then the last question that we have is, what areas currently provide medical assistance in dying in the province? So as of right now, the WRHA has the Medical Assistance in Dying Implementation Team. As of right now, they are the only group that is providing medical assistance in dying. My understanding, again, is that some of the other regional health authorities are in the midst of exploring these options and whether they are going to implement their own teams as well. But as of right now, it's the WRHA implementation team that is covering access within the whole province.
And I'll just add further to that, if anybody has any questions specifically for that team, I believe you can go on to the website and you can send them an email or contact them. Their contact information is available on the website if you do a search. They do welcome any inquiries or comments that they have from the public or from practitioners, from my understanding. You can just search them on the web.
Okay, so we have another question. I understand that the age is 18 for consent and the person must be competent. Any comment on those who are decision makers for children and those with Alzheimer's or other illnesses that consent has not been obtained? This is quite a loaded question, and there's a lot of work that's being done on a national level in terms of addressing the mental health piece and the age of consent and the competency of the person who's providing consent on that basis. I can't comment specifically in terms of what your role might be as the nurse in that case if it's someone who's under the age of 18. I think in that case it would probably be appropriate to consult either with the Medical Assistance in Dying implementation team or amongst your colleagues. As I said, there's a lot of work that's being done nationally on those three areas, and I would imagine within the next year or so we're going to find out more in terms of how medical assistance in dying applies to those with mental health issues, those who are under the age of consent, and those with advanced care directives.
So we do have a question about, to date, do we know how many individuals have utilized the MAID process in Manitoba? And we have heard this in the past, but I can't say that I'm totally current in it. We've heard that there's been up to 80 referrals and around 20 people who have accessed the service. So that's all of the knowledge I have. I don't have anything current than probably more than a month ago.
There's a question here for what is the website, and I'm assuming the question is the website for the Medical Assistance in Dying implementation team. You can actually go to the WRHA website, and they have a link to the Medical Assistance in Dying implementation team, and they have a whole web page set up for the Medical Assistance in Dying implementation team. So we have another question. Does the Medical Assistance in Dying team travel to other areas, or would the person have to go to Winnipeg for the service? My understanding is that the Medical Assistance in Dying implementation team are traveling outside the province, and they have gone to other regions in order to provide the procedure.
So we do have a question that says, which hospitals are currently accepting patients who have made requests for medical assistance in dying? And to my knowledge, St. Boniface has opted out, and also Concordia Hospital. Those are the two that I'm familiar with.
We have another question. The question is, must a nurse provide regular day-to-day care for a patient who wants medical assistance in dying if they aren't okay with medical assistance in dying itself? So if they have a conscientious objection to medical assistance in dying. So that is something that's the reason why we do recommend that nurses are reflecting on this now before it does come into your practice area. And as Ryan alluded to earlier, a provider may find themselves thinking, okay, I think I've decided where I sit with this, and then it comes and you're not exactly certain and you find yourself in conflict internally. It is a great idea to gather as a collaborative team with your staff and your colleagues and your employer and have these discussions ahead of time to try to come to maybe a plan about and identify, which staff members, which nurses are okay with participating and contributing to care to somebody who is going to be receiving a medically assisted death, and if there are staff who have already made the decision that they, some feel they're okay with being on the unit but maybe don't want to provide any type of direct care and can continue with their day-to-day care with other clients on the unit and just kind of abstain from the room altogether. Some feel that they can't even be in the building. It's just something that internally they're just not sitting well with because of their own personal feelings and values, and that's something that you should openly discuss wherever you sit on the topic with your employer, to then come together as a team and implement a plan on how you can all cohesively still support each other, support the client, and all the other clients on the unit. Because as we discussed earlier, we all have our ethical duty to provide care, but you do have your right to have a conscientious objection, but you do need to engage in conversations with your employer and your team to develop a plan.
So we have another question. Are there facilities that have developed their own policies around medical assistance in dying, and whether or not it can and how it will occur in their facility? I think this is pretty much an employer-driven type of question, and it really kind of comes down to what employers are willing to do in terms of how they're going to implement this. We did do a consultation a couple weeks ago with the staff from Riverview and Palliative Care, And it was a bit of an eye-opener for me in terms of not only how it's being accessed on very specific units within very specific facilities, but I feel that they've done a terrific job in terms of addressing it in how it looks at their facility within their program. So to answer your question, yes, my understanding is that some employers are developing their own types of policies, and in the way that they're addressing these issues as they occur in their facilities or on their units. This is still relatively new. We've really only kind of been dealing with this for about 5 to 6 months, and for some facilities and some programs and some units, they've maybe only had one request. So I think this is still very much in its infancy stage in terms of how employers are going about addressing it.
So I see we have one more question. It says, is this service currently available in community homes or in hospital only with the MAID team present? If not, would this eventually be an option for people? And it's not occurring only in homes. A number of people have had medical assistance in dying in their own home. Sorry, not only in hospitals. And as far as the team being present, because we only have the provider provision of medications available in Manitoba, and it's not the assisted suicide medications are not available. It's only the medical assistance in dying team will be available for those this type of service, I guess. So down the road, when we do have the medication, the other option will be available. So thank you again for joining us and for your really great questions. We will close for today. You will have the opportunity for a survey at the end of this, and so we certainly appreciate your feedback. And if you do have questions after we've finished this webinar, we certainly welcome your questions from the individual colleges. So thanks for joining us. From Darlene,
Ryan,
and Tracy.